Good afternoon. Welcome to Let's Talk About Cannabis and Healthcare. I am going live, so I'm making sure that all my connections are all set before I get going and introduce you to this week's speaker. If you're joining us early, the improvisation was at Flower Expo the last 2 days, making connections, really being having conversations we need to have within the cannabis industry as well to bring them awareness about the work we're doing. So I'm commuting back, and we're still getting this done because we got to get it done. So I want to make sure that I'm connected in all the audiences that I'm supposed to be connected in, and we're gonna go ahead and introduce our guest speaker today, which I'm very excited about. This is someone I've known for a very long time, but also really deep in the work. So if you are just getting to know us now, my name is Trudis. I'm your host, and this channel is called Let's Talk About Cannabis and Healthcare. And we are essentially a platform that exists to help inform not only healthcare and providers about what needs to happen to really responsibly integrate cannabis into the healthcare system and what we should leverage and the data we should be collecting and the conversations we need to start having to ensure that this is a responsible transition and that we're able to support people in the ways that we have before. So that comes a lot of questions and a lot of conversations. And I want to introduce Zoe Andalcio. He is a licensed mental health counselor in the state of Massachusetts. He is also the co-founder of Supportive Minds, a private mental health addiction group practice. He also serves as the co-chair of the Addiction Counseling Division for the National Association of Black Counselors, a graduate of Xavier University of Louisiana and Northeastern University right here in Massachusetts, and I will say Boston Latin School as well, even though it's not in his bio. He is dedicated to advancing equitable access to mental health and addiction services here in the Commonwealth and beyond. He has over 17 years of experience and has trained in several evidence-based approaches to dual diagnosis treatment, and I am super excited to bring him onto the stage. Welcome, Zoe Andalcio. Now, the reason I felt it was so important for us to have a conversation is because we've had a conversation in the past that was when I was trying to better understand cannabis use disorder as a diagnosis and what it meant for the continuum of care. Because in my work in collecting the data, like to kind of establish evidence-based care pathways for the integration of cannabis in healthcare, harm reduction is a big thing that cannabis tax dollars are being spent on in the state of Massachusetts. Yet the cannabis use disorder diagnosis doesn't have a harm reduction pathway or care pathway, or we don't have metrics or data. So I wanted to better understand that. And you gave me a mini lesson, and I asked you to join this audience and please support us in learning a little bit more about harm reduction, cannabis use disorder, and where this conversation fits with your experience and your research background. Where does this fit in the harm reduction and what needs to exist for us to really have a harmonious integration from the mental health perspective? So welcome, Zoe. I'm gonna give you the stage and you let me know when to share your slides.
Okay. Well, thank you so much. First of all, I want to thank you, Judas, for this opportunity. Like you said, we do go way back, and it's always great to reconnect and to show that my former classmates are doing really big things. So I really appreciate this platform and what you are also doing, in this conversation today. So thank you so much for that opportunity and that introduction. I appreciate that introduction as well. Yeah, so I thought that I would start by showing some slides. The whole purpose of showing the slides is to kind of ground us in some historical content, but also kind of ground us in, I know a lot of your audience are maybe addiction nurses or other people, but maybe not counselors. So kind of ground us also in addiction counseling and kind of the evolution of where it started and kind of where it's going right now. I have some slides to kind of help us with that. And then following that slideshow, we can, get right into some questions.
No, absolutely, because I have some fun ones, especially after spending some time with the industry. I definitely have some fresh ones, but I'm going to give you the stage and I want you to go ahead and take us away. You are sharing your slide.
All right, thank you so much. Yes, so I want to start off with basically talking about the history of cannabis use, kind of globally, and then move into a direction of talking about it more domestically. So many of you guys probably already know, but cannabis, the plant, has been around for thousands of years. The earliest evidence of cultivation dates back to about 10,000 years ago in regions of Asia, like in China and present-day Mongolia. And so this plant has been around for a long time. It's been cultivated for a long time. And the earliest evidence of it being used medicinally in a very systematic way was in 2700 BC. So the reason why I point this out is because this plant has been studied and has been utilized for human consumption and in medicinal ways, but also in ways in which it can be helpful. So, for example, they've used it as food, as protein, hemp seeds as protein. They have also used it primarily as fiber. You can make ropes and nets and other things with the cannabis plant. So it very much was integrated in these societies. And the seed of the cannabis plant has traveled all over the world. And I make a point here to talk about the even during the Middle Passage of slavery, enslaved people would carry seeds of many plants that were indigenous to their home country, but including also cannabis seeds. And that cannabis seed was then planted and then used by everybody in the caste system, including some of the royal families or the royal colonial oppressors were also using it. The famous example is the Queen of Portugal during the Napoleonic Wars was in exile in Brazil, and she was known to be using cannabis for things like headaches and all kinds of other things. But the first European to study cannabis happened in 1833. It was this Irish physician. And then after that, there was a French scientist who also studied it. And they studied how they were using the plant in some of the Asian countries that were using the cannabis plant. So the question, I guess the question is how does it go from being studied, utilized, widespread to where we are now in the modern era, all right? Where we are celebrating it becoming a Schedule III drug. And so we really have to kind of go back in history to understand why. And so what we need to understand is that prohibition was not an accident. Prohibition was a very deliberate, the prohibition of cannabis was a very deliberate way of basically trying to maintain the status quo, and the status quo being white supremacy at the time in the United States. And so with the passage of prohibition of cannabis in 1937, there was a whole lot of work that's being done by the government, on behalf of the government, to basically alienate and marginalize people and to create this sort of moral stir amongst the mostly white folks. And that's how a lot of these legislations got passed, and including the prohibition of marijuana. We also have to talk about the wars. The war on drugs obviously has been documented. Everyone talks about Michelle Alexander's The New Jim Crow, but really talking about how the criminal justice system at every single level of the criminal justice system, whether it be from incarceration to pre-trial to probation afterwards, has basically perpetuated the social control of Black and brown bodies. Drugs were used as a way to lock people up, right? And so that is really important. Vietnam War, when soldiers where in Vietnam, there was a different type of cannabis plant there that was a little higher in potency. And they brought some of those seeds back into the United States. So most of the cannabis that was gotten in the United States prior to that had very low potency THC. It was very balanced with CBD. And I could get into what THC and CBD and cannabinoids and all that stuff is later. I'm assuming that you guys are well educated on that in this group. And so, as a result of the war on drugs and prohibition, people were getting arrested if they were planting it outside, and people were getting arrested if they were researching it. So prohibition basically shut down research because it was too dangerous and too risky, and shut down, growing the plant outside and in fields. And so what that forced people to do is to grow inside, and that sort of enforced behavior then allowed people to really start to manipulate the plant. And it's through that manipulation of the plant that the potency went from in 1970s 2 to 4% THC all the way to in the mid 2010s 12 to 17% was the average THC amount, and all the way up to now what we see now, which is cannabis flower can be up to 33% THC, and some of these cannabis concentrates like the dabs and the waxes can be up to 95% potency. So we're talking about a completely different plant. And a lot of it had to do with the way the plant was basically put in a one way I've heard it said before, put in a legal straitjacket. Like because of the legal barriers to it, it has helped aid and abet this modern era of this big potency increase. And so that's what we see now. And so oftentimes when people talk about the dangers of cannabis, they're talking about it from this very high potent, sort of genetically modified plant. And there's a lot of factors for why this happens. I mean, obviously now there's a market demand for higher THC, and so that drives it. And also with a lot of this cultivation happening indoors and within climate control and selective breeding, all those different things, that has also helped sort of move the potency, sort of potency increase of what we're seeing. Obviously, with a higher potency, there are health implications. Most of the time in the sort of addiction field and psychology, we talk about these health complications as affecting specific demographics and specific populations, but we also talk about it as affecting other co-occurring mental health sort of challenges like anxiety, depression, and psychosis. And so we can certainly have a more of a robust conversation about that. So it goes from being a plant that was cultivated and integrated and used for medicinal purposes, and also used for practical purposes like for fiber and for protein and the hemp seeds, and all members of the caste system using it for it to be studied. And then now we're in marijuana is still federally prohibited, even though it's Schedule 3. Only certain products are allowed, to be used. And so now we're in this area of prohibition and this area of this really extreme potency level of the marijuana plant. So I wanted to talk about harm reduction real quick, just to tie in how harm reduction and addiction counseling kind of overlap in some ways. So just for educational purposes, harm reduction started out as a grassroots, peer-led, mutual aid response to marginalized folks who basically were being ostracized by the healthcare systems, ostracized and targeted by the criminal justice system and things like that. And it's really important to center the people who led the harm reduction movements were queer, Black, Latinx, drug users. There were people who already were at the intersection of a lot of marginalizations. And they basically said, no one is going to help us. We have to help ourselves. And so they set up organizations like ACT UP, but they also set up programs, like underground programs to help people once they started to notice that HIV and AIDS was being spread by needles and all kinds of other ways. And so they set up programs and ways in which to help. And their whole message really was this idea that it doesn't matter what your background is, you deserve to live. And you deserve to have access to help you live, to reduce that harm. And so that's where it came from. It didn't come from any large institutions. It didn't come from any federal institutions or state-run institutions. It really came from folks who, were in the trenches, were already dealing with a lack of care and services. And so now that philosophy, because it really is a philosophy of how to care for folks, went over into the addiction world. Using that philosophy, there's a certain way in which you look at addiction. They don't look at addiction as a moral problem. They don't look at it as even a medical problem per se. They look at it as a very complex human experience. And if there's two things you get from just talking about harm reduction, it's this idea of safety and engagement. They basically want to increase safety and engagement. And they say that if you are able to do that, when we say if we're able to do that, then that is the way in which you can really help. It's about not necessarily achieving abstinence, but about reducing the risk and harms associated with use. Sometimes you can get it through abstinence, and sometimes not. And they're saying that abstinence should not be the marker, or should not be the way in which somebody gets access to support, to healthcare, to housing, to dignity, and to compassion. And most importantly, they believe that substance use, exists along a continuum, right? So on one end of the spectrum of substance use is what they consider beneficial substance use or medicinal substance use. Then there are people who they consider recreational use, which is non-problematic use. And then there's risky use, problematic use, and then what they would term as substance use disorder. So this is important to understand because harm reductionists were kind of saying this for a long time. And in the next slide, I'm going to show you the evolution of what psychologists and psychiatrists and mental health therapists, their evolution and how it kind of, it's actually trending in a direction of harm reduction, even though there are many pieces of it that it's not harm reduction. So when I first got into the field, I was basically taught that there were two categories when it came to substance use disorders. There was someone who fit in the abuse category or somebody who fit into the dependence category. And in order to be in the dependence category, you have to have be able to meet certain criteria, plus have what they would call withdrawals or tolerance, evident. And so this really kind of created this binary that you were trying to assess to see if somebody was an addict or not an addict. And through these binary sort of frameworks, it really put more emphasis on the label than actually on the person's experience. And so it was in retrospect, thinking about it, it didn't really talk about any of the other possible ways in which someone can use substances. And so there was no way to kind of even talk about prevention or anything along that lines, because it was so geared on severe use. And then in about 2013, in the new DSM-5, it shifted to talking about it from these very binary categories to talking about it in terms of a continuum, which is very similar to what harm reductionists were saying, that it lies on a continuum. And basically why they adopted this continuum was that they started to see a lot of the research basically indicate that the continuum model was a better way of reflecting what was actually the clinical reality that folks were seeing in the community, in their offices, and things like that. And this is a very significant conceptual shift, because it moved addiction away from being an all or nothing kind of framework towards a more dimensional understanding of problematic substance use. And as you can sort of tell, it opens up varying degrees, and it recognizes varying degrees of risk, impairment, or need for support. And so even though it's doing all of this, it's really important to also say that it's still very much a kind of a medical model. It is not, it doesn't reflect anything that necessarily that is social or harm reduction oriented. However, it is a vast improvement from what we had when I first started in the field. And what we gather from this too, once we start looking at it from a continuum framework, is that we start to notice certain things. Like we start to notice that most cannabis users do not actually develop severe cannabis use disorder. And I talked earlier about specific populations. We start to notice different things when we're able to do research and think about it on a spectrum. We start to notice that certain populations, like adolescents, mostly because of early brain development, there's a higher risk of sort of developing problematic substance use. For people who are using these higher potency products, there's definitely higher risk. For people who have co-occurring mental health conditions like psychosis or schizophrenia, for example, and for individuals with certain genetic or environmental vulnerabilities, so clients who have maybe a genetic predisposition to addictive cannabis use, they may be at higher risk. And so this way of thinking about a continuum also does something really important, which it helps to eliminate a lot of the stigma that was perpetuated, right, by these binary frameworks. Because binary frameworks encourage labels that can obscure basically what a person's actual experience is. And so, going from like this idea of an addict or not addict, oftentimes we hear things like, well, if you use, you're irresponsible. And if you don't use, you're responsible. Or, you're either addicted or you're healthy, or, either you're in recovery or you're failing. Again, all of this sort of language is very much part of those binary frameworks. And so the significant shift is kind of over time also shifting that language. Okay. So this next slide really speaks a lot about some of the significant sort of policies things that have deeply impacted cannabis. And so we start off with prohibition in 1937 with the Marijuana Tax Act. And I want to say something about this because this is super important, I think. Before this Tax Act was passed, there was a lot of propaganda and a lot of sort of fear mongering that allowed this to pass. So right, the year before this, there was a film that came out called Reefer Madness, and some of you guys may have heard of it. But basically, that was a complete propaganda film. The film was about these drug dealers who were turning teenagers into basically drug users and addicts, as it would say. And it was very racially charged. I think in the this slide, I talked about the prohibition having all these racist origins. So this was also a way in which they sort of perpetuated these racial tropes. And so Reefer Madness was all about this idea that Black and brown, especially Mexicans, that's why they call it Marijuana Tax Act and not cannabis, because they really wanted to hone in on this racist ideology about Mexicans and its connection to cannabis, and also this connection to like white purity, right? And so they would say that these Black and brown people who were using marijuana would more susceptible to doing dangerous things, to trying to intermarry with white folks, all these things. And so they were able to basically wrestle up this hysteria that allowed the passage for the Marijuana Tax Act. And that's first when in this country, cannabis was prohibited. And then in 1961, basically cannabis, they started to schedule psychoactive drugs into different schedules. And Schedule 1 is a schedule where psychoactive drugs are considered to have no medicinal value, and they're purely just for abuse. And so that's what the federal government is doing. And in this slide, you start to see that there starts to be this shift from state governments to federal governments. And you start to see state governments start to slowly decriminalize and legalize. And a lot of that had to do with the actual citizens of the states. And so as state governments start to do it, now we're at a place in 2026 where the federal government, for the first time, the U.S. Department of Justice for the first time, is dropping certain marijuana products from Schedule 1 to Schedule 3. And why that's important? Because it does really four major things. One, it acknowledges that there's some medicinal value of cannabis, which, I mean, if you were a student of history, you kind of knew that, because for thousands of years, they were kind of using it that way. It also helps reverse some of the IRS restrictions. So as we start to see more venture capitalists and other people getting into the cannabis industry, this removal of these restrictions allows them to take ordinary business reductions. So that helps them on the bottom line. The third thing it does, it eases certain research barriers. So now we can actually start to research and try to basically catch up to where people in the past were, doing some of the research on it. Now, granted, it's a completely different plant now. And so it eases up these research barriers. And then the fourth thing it does, it starts to influence hopefully future federal legislative efforts in sort of like this global validation for medicinal cannabis. And what we know is that what happens in the United States definitely impacts what happens on a global scale. It's really important to understand that, like, a lot of what we see policy-wise happened at various different points in time in history with various different empires and different things like that, as a way of social control. So when you live in a caste system, which we live in a caste system, we live in an economic caste system, right? When you live in any kind of caste system, in order for the people at the top to control the lower class or lower caste or the minority people, they move to outlaw certain things that have become a part of their lives, and substances have often been the thing that they move to sort of control. And so this is a form of suppression. This is a form of control. And so it's really important to understand that. And as addictions counselors, it's really important to understand that history, um, and understand what are the limitations to the DSM in terms of fully understanding the scope of substance use behaviors and experiences. This last slide, real quick, is just some resources for data. A lot of the data that I've talked about, it's all documented and written, and I just encourage everybody to go out there independently. Do your own research and kind of see what's going on. Drugs is very easily propagandized. It's very easily used to other people historically. The other thing I was thinking about with these policies is how much, for example, they've been used to sort of demonize black people, black and brown people, but black people. If you think about, if you guys remember that movie, I think it was called Billie Holiday versus United States, or United States versus Billie Holiday. But basically, it was about the story of Billie Holiday and how the United States government used basically drug arrests to suppress the political nature of some of the songs, right? And that's just one example in history how drugs have been used as a way to disenfranchise people. So it's really important if you're doing this work to understand that and not to replicate those kinds of things by trying to make drug use a moral issue or sort of some sort of moral failing. Um, all right, so that's it so far. What I have as far as this presentation, the slides go, but
Yeah, I thank you so much. That was very in-depth, very fascinating, and it feels very timely as well, because I think as we start to think about how to adjust to the Schedule 3 rescheduling, which um, first forces us to first define what that means in our own states, because the state government, we have a dual licensure medical program and we have an established medical program. And once we've defined that our medical program is qualifiable and we start to really create the pathway for the medical treatment centers and the industry to get registered with the DEA and go through all the steps to be acknowledged at the federal level and get those benefits, we need to begin to think about the clues that history has left behind for us to really learn fast. And I'll lead into this by saying something I shared a lot this past few days over at Flower Expo in Northampton. It was a cannabis business industry, and my curiosity has always gotten me in trouble a little bit, but I find that I I asked a question that made me go on this nosedive into harm reduction and what it means. And it was after prohibition, because there's been a lot of comparison with cannabis and alcohol, especially
Mhm.
from the medical field and on the provider side. Typically, we've been taught to look at only the negative outcomes of engaging with the plant. So there's either a dependency or use disorder, and which means from the clinical perspective, we're making referrals to addiction services that you don't necessarily need. Um,
Mhm.
but if there is um, clues in our history, like with alcohol, with opiates, that there is a propensity for a use disorder. How did we figure it out, right? So my question was, after prohibition, how long did it take healthcare to realize that alcohol use disorder was going to cause poor health outcomes, and that we needed to build guardrails around the use and then build supports? So you told the story of how the supports came about. And I think a lot of the supports always come about from the front lines, people who feel marginalized. They
Yeah.
always stand up to to speak. And I think organizations like Americans for Safe Access, they're the ones asking to be seen as patients and asking for a system that sees them And that movement is going to not only have more strength now that there's a federal mandate, but it's going to start to pressure test. What are you going to do about this? Because these are millions of patients
Yeah.
in these medical programs. But then it makes me think, are we collecting the data to materialize or be able to see if we start to have trouble, where the trouble is coming from,
Hmm.
and what have we typically, like, how do we figure it out? So with alcohol, I'll tell the short story. With alcohol, it was that like people started seeing mortality, then the police and public service started seeing violence. There was a lot of social clues, and they were, the common denominator was alcohol, but it took like 40 years for people to really understand that there needed to be a strategy and to
Yeah.
barriers and dosing, and like, hey, alcohol's bad, and no, you can't make 99 proof alcohol only and moonshine. Like, they had to build the guardrails, and then the industry adjusted so that it could exist as a safe consumption option. And
Yeah.
then the people that were not protected initially were like, now, like, protect us, right? With opiates, this is the most interesting part, because opiates are Schedule 3 medication. The reason we were able to catch the opiate epidemic quickly and interact quickly and now see data to result that in the harm reduction efforts have been positive is because we were already collecting the data to allow us to see the trends. So when
Mhm.
we saw, and the joke, well, it's not a joke, but the trigger to pain becoming the hyper focus is that pain became the fifth vital sign. So as a nurse, if you look at the data, when pain became the fifth vital sign, we began to teach pain as a vital sign. So now you need assessment pathways, you need severity controls, and now you need new medications, and you need new things to support that. So and because we were capturing this medication, knowing that it was a scheduled medication, and we were able to see the trigger when it went bad, even though we missed it by a few years because there were still information silos, but it was a
Yeah.
lot more visible to us because we had dosing information. We understood, we had visibility to how it was being prescribed. We started seeing people reporting pain related symptoms or opiate dependence, people asking for resources for opiate dependence. And these conversations triggered the awareness for the working group to get together and say, hey, we have an issue here. What do we need to do? And then move into the accountability. I believe cannabis has a very therapeutic use as a provider, as a patient. I would love that if there is any chance that anyone will misuse this, that we build the infrastructure to be able to see it quickly. Like, we have too much technology, and we have too many bright and brilliant people, and we have too much existing infrastructure and framework for these things. But I think it's the stigma and the story that this is, like, that is so attached to it, that is not allowing people to see that we need to collect the nuanced information, because if there is a problem, we have no visibility to it. Like, we just can't see it.
Yeah.
So in that sense, what are some of the needs in terms of data that the
Yeah.
mental health community needs to see? What are you trending? What do providers, like, if I'm a clinician and I have a clinic, what can I start to think about adding to my data capture so that when
Yeah.
you have a question, or so we can have a trend, like, what do you need to see to see if this is going in the wrong direction?
Yeah. Well, I mean, very good question. First of all, I'll say that in many ways already has gone in the wrong direction. And a lot of that has to do with the fact that there hasn't been enough opportunities to research cannabis. And so, you could put that squarely on prohibition, on not allowing, what started in the, 1800s to continue. Um, I would say this when you talk about pain, it's interesting because when you think about medical invalidation, you think about those consumers who go to hospitals reporting pain. There is such an overlap of what we're talking about here. Because if you're a Black and brown person, you often are not, your pain or reports of pain are often being invalidated. If you're a substance user, for sure, your pain is being invalidated. And so it's really important for us to understand more about how these um, structures are basically perpetuating these kind of well, not kind of these racist and marginalizing viewpoints on what pain is, on what addiction is, what all of these things are. And so the thing that has been convoluting the conversation that no one's really talking about, and it actually happened back when they passed the Marijuana Act, is the role of big corporations. So back in 1937, the big corporations was Hearst family, and the Hearst family had an intrinsic interest in making sure that marijuana was stamped out because they needed the fields to be clear, so they can have their own resources grown on that family. So they partnered with the Federal Bureau of Narcotics to basically try to stamp out and eradicate and prohibit marijuana. Now we jump back to 2026, and you think about how these corporations and these big corporations are also, sort of fueling this lack of sort of real clinical information. One of the biggest things that in the counseling field now we're talking about is AI, and how many people are using AI versus coming to therapists, or versus trying to and how many of our health centers and institutions are being run by AI rather than by people. So there's this huge overlap, I think, with corporations and market demand that basically gets in the way of us actually getting the true data and actually getting the money in order to extract the true data. And we also have to look at how certain populations are continuing to be marginalized, especially when it comes to the healthcare systems. So if we're not addressing those two things, it's going to be really hard, I think, for us to really get to the heart of what the issue is when it comes to cannabis.
No, I think that that's so important because I think it was last summer, that there was a call for papers on commercial determinants of health and how these commercial and policy and business decisions and are impacting health outcomes. And in the beginning of the work that is now this, it
Mhm.
started with trying to figure out where profits were coming before people, right? And
Mhm.
where we could acknowledge that, yes, there needs to be profit, but we need to mind the people. And a lot of that research for me came in kind of comparing the databases from the Department of Public Health, because we have a huge health equity problem here in Massachusetts, and it's
Right.
documented and we can see it, so we can't hide anymore, right? So the
Yeah.
state allocating resources to bridge those gaps, which is the right thing to do. But now we're using all these dollars that cannabis taxes are paying, right? Which
Uh,
are there. There's a threat to that too. So I'll get on that in a few minutes. But we're using these dollars for harm reduction services and not
mhm.
servicing the population that is at most risk with the funding that is generated from their sale. So there is no infrastructure, and no capture and no medical accountability to the cannabis patient, but the cannabis dollars are funding everybody else, right? And there's an infrastructure and there's a responsibility that we have to be able to see this, because if we're truly trying to reduce harm, it
Yeah.
begins with being able to see what is happening. And
Right.
if there is something that is happening that is not good, that we're able to intervene early. And prohibition has never been the answer, right? Because you
No.
said something, I
No.
wrote it down: safety and engagement.
Yeah.
And this is where this comes in for me. Safety and engagement is so important. And as a clinician, I'm very much very passionate about this, because there's a ballot initiative in the state of Massachusetts right now. And they branded it so in such a manipulative way. The name of the ballot initiative is Restoring Sensible Marijuana Policy. And
Mm.
essentially, their ask is that we get rid of the adult use industry and we only have medical. and that we get rid of all the programs that adult use industry funds, and that we just force everybody back to whatever other source they have. Because there's something that when you are binary, you said binary framework, and I wrote that down. And this
Yeah.
policy has a binary framework, and their argument is that cannabis has caused more public health harm than than actually supporting public health. And I'm like, how do you make that argument if we don't have any public health data? Like,
Right.
and they have the
Yeah.
isolated cases of the psychosis, because those are the things that are alarming when we have
Yeah.
young people who are at
Yeah.
risk, and
Yeah.
then they're exposed to an untested, high potency,
Right.
illegal substance. And
Right.
then we see those cases, and those are real, and we need to build guardrails for those. But the reality is that if we shut down the adult use market, we're shutting down 80% of therapeutic consumers that are on the social and functional
Yeah.
side of the harm reduction continuum for cannabis. And
Yeah.
we're just basically saying you don't exist. And there's no
Yeah. Yeah.
and,
You're
and those patients deserve access, right? They
absolutely.
deserve, you didn't like, if I need really high dose ibuprofen, my doctor gives me a prescription. But if I don't have any issues and I can self-direct my headaches and my care, I go to CVS and grab me an ibuprofen. There is a time and place for both things to exist. And the responsibility for both things to exist is education, so that I know how to use it when I'm being self-directed. So I think
Yeah.
there's a responsibility on the cannabis industry side to stop pushing for high potency items, like you called out, because that's what's causing cannabis hyperemesis syndrome and a
Yeah.
lot of the adverse effects that we're seeing.
Yeah.
We're not intentionally consuming it.
Yeah.
So now, being a nurse, and nursing being the only specialty that has cannabis as a specialty of practice, and we have standards and guides of practice as it relates to cannabis nursing, it is so important to really start to think about your strategy. There's as a clinician, like, how are you going to integrate this patient experience? How are we going to look at the data for harm reduction? Do we want to get caught with our pants down? Do we want to have a formulary or like a care pathway when we discharge these patients? What services are we setting up? How do we know they have a ride to the dispensary to get their medicine? Like, these are all social services that are available to
Yeah.
us now. And we're not doing that for cannabis patients. We're not serving them in the way that they deserve as part of like this framework that exists to support. And I think
Yeah.
that that's unfair, not that we need the data for it, but it really begs the question, like, where do we start this conversation, and
Yeah.
who does what and who holds what? And I'm just excited to be able to have these conversations, because then we can mastermind, and maybe somebody
Yeah.
will hear this and go, I think that there's a way. And then the conversation needs to happen. And I hope that these are seeds planted. I thank you for like your intellect, your time, your feedback. And I want to just invite you to, like, I don't see any questions. I'm kind of monitoring the chats
Yeah.
in here, but I wanted to know if there is anything that as I shared back that you
Yeah.
were aware of. Yeah.
Sure. I mean, I think you're absolutely right. I think we have all the necessary things in order to do this in the correct way. But at the same time, we have two different systems. So I'll take it back to this idea of the spectrum on the DSM, right? Even though the DSM sees cannabis use on a spectrum, a lot of the systems in place don't see it that way, right? So you have treatment systems that don't see it that way and don't operate in that way. One of the things about Massachusetts especially is that while we have all this research here, Massachusetts is one of the largest systems of involuntarily committing people for substance use disorder, right? We have one of the largest systems. So in one hand, we have all this research and all this, progressive, recreational marijuana and stuff. And on the other hand, they're basically sending a message that if you use a substance and you do something that is sectionable, then we will section you with quickness, right? In that sense, this involuntary stuff. So we have to understand how these two systems are connected. You can't on one hand say, we believe in the inherent right of people to use marijuana recreationally, but then the minute somebody maybe has psychosis or does is driving or whatever it is, also have a system to involuntarily lock them up, right?
Because that what you're doing is I I'm going to say this, and I'm not sure if these are the right words, but it's almost like when you incarcerated people, like you're now like you're criminalizing being a patient within the healthcare system because you can only be locked up involuntary. Like that's what it feels like when you said that. I was like, so what happens when someone it has therapeutic use? Because again, the nursing specialty guides for cannabis nursing, therapeutic use is very clearly defined and it's on the spectrum of use disorder. So when you said that, I looked back at our definition and maybe this is again an opportunity for people to online language, but therapeutic use is use of cannabis for benefit without affecting the other five domains that if you kind of slide into, you end up, being at risk. Um, and we don't acknowledge that as part of the public health infrastructure for cannabis, but we do for
Yeah.
everything else because we assess therapeutic social use of alcohol and we don't
Right.
assess social or therapeutic use of cannabis. So we're not like the infrastructure and the governance of the data is biased and stigmatized. So
Yeah.
like we
Yeah.
have to start at the basics and instead of asking people, do you take illegal drugs, yes or no, intentionally ask about cannabis consumption and start to assess what consumption looks like because that's the
Mm.
other part. When my
Yeah.
I founded Project Destigmatize Healthcare. For those of you on the other audience side that don't know, I have a nonprofit that does research and our goal is to really destigmatize how healthcare looks at human behavior, starting with this amazing case study of cannabis, right? And this is so obvious that it's easy to target, but we don't have the data capture to say what does regular consumption look like. So like if
Yeah.
somebody says I smoke every day, you think they're, oh my gosh, this is like the worst human in the world, but I smoke every day. Like I don't know what else to like if that's consumption.
Yeah.
Like this fun, like we don't have a baseline. We've never asked
Yeah.
people who are benefiting, like we've never
And
asked the person who got off their seizure meds how they consume what dose to try to see the patterns that are helpful for others and learn from this information. We've never asked the person who is, not suffering with Crohn's disease anymore, what their
mm,
use pattern is to learn. And that's part of research too, right? To learn from the information. We don't tell the positive cannabis stories because most positive cannabis stories include letting go of traditional farm and pharmacotherapeutics. A lot of people have gotten off anxiety meds and sleep aids and are using cannabis instead. And if you tell those stories, it creates this tension. But I think we can coexist. I think cannabis, as it exists, can coexist with whatever is coming next for cannabis in terms of pharmacy and what their research and because that's a different lane. But I think this one deserves its own seat, and we
yeah.
need to allow for therapeutic use to be documented,
Yeah.
captured, so that we can learn the lessons from the people who've been doing the work of learning how to use this therapeutically for years. Like, why are we asking other people? We have just asked the patients. They'll tell
Yeah.
you why they're using it. They'll tell you how they're using it. They'll tell you why they're not telling you they're using it. And I
Yeah.
think that like that's the biggest missed opportunity in this space right now.
Well,
We
I think,
with patients
yeah,
and we talk to them.
yeah, I think what you're saying is because people put labels on what's therapeutic and what's not. We just need to talk about use, and in a non-judgmental, curious kind of way, and ask the question. So, like for if I'm trying to supervise a early career person, it's not about trying to figure out if this person is addicted or not. It's really asking how this behavior or this use is affecting their life in different domains, right? And being curious about it. Also being curious about how it is. I often say it is adaptive. It's not this idea that substance use is maladaptive. It is adaptive for their life. But what do you understand about their life in order for you to see that's adaptive for their life, right? Something being adaptive doesn't mean it doesn't have negative consequences in other domains. It just means in that particular way they're using it, it is quite adaptive for them, right? And so that's really important to point out. And the other thing too is, if we look at this idea of social control, you can understand why they're sort of trying to legislate certain behavior. Well, if you use it for cancer, then it's okay if you have cancer. But if you're using it, given that analogy of Billie Holiday, if you're using it, with music or whatever, then that's not okay. And so we have to be very careful when we start to put the label on what is therapeutic, what is medically, what is appropriate on any kind of use. Because already we are starting to set up a caste system. We're starting to set up a hierarchy, right? And that starts to basically resemble what what oppression looks like. And so I think, like for me, one of the important things to understand about the mental health system is its close link to the carceral systems, and to understand that that connection has already been there. That people have used psychology as a way to basically pathologize people or to tell people that there's something wrong with them. In the 60s, they used it to label Black men with psychosis because they were angry all the time and not really understand the context of what was going on in the 60s, right?
Yeah.
Recently, psychologists were used in the military, with the CIA, all these different things, to further empires and all these different things. So we really have to understand that we're closely connected, just like the medical field is closely connected. Just like the anthropology field and the sociology field and the public health field is closely connected. But when you have brave souls like W.E.B. Du Bois, who basically debunked back in the 1903, I think he came out with the book where he basically debunked what was public health saying about Black people, and they were basically saying that Black people had all these diseases and stuff because of they were eugenics wise they were inferior. But what Du Bois was basically pointing out was that no, they were basically effectively refugees after the Civil War ended. And so anytime you have a group of people who were forced in this only a certain area, i.e., what's happening in Gaza and other places, you're going to have proliferation of disease and all kinds of other things, right? Especially if those people don't have access to medical care and things like that. So I think it's really incumbent upon those of us who have awareness to speak about not only about ways in which we can kind of look for these nuances in use, but also speak loudly about how the system and the field that we're in is being used to prop up the status quo. And the status quo right now is it's almost like a lot of the advancements we've made didn't even happen. We're kind of going back to this place of mass social control in many ways. And it's really important to see how cannabis and other drugs have always been a part of that campaign for social control. And that's where harm reduction comes in, because harm reduction basically says explicitly that a person's value is not predicated on whether the person is using substance or not. It's predicated on the fact that, just the dignity of that person. And so that's part of the reason why I'm I consider myself someone who follows the harm reduction policy, sort of philosophy. I'm not saying that there isn't, severe substance use disorder, or there isn't certain populations that are vulnerable to substance use. I'm not saying that at all. All I'm saying is that what we do know about the research so far is that the vast majority of people who use substances do not have problematic substance use disorder, right? But yet the vast majority of people who use substances have been vilified and have been marginalized and stigmatized. And that is not helping any society to have stigmatized people, right? And so we have to understand why this is happening. And you have to understand who's benefiting from people being stigmatized, right? And so when we look at what's cannabis is a perfect example, now it's becoming more mainstream. Why is it becoming more mainstream? Who's benefiting? You
Yeah.
know, where follow the money. How is this is happening? And most of the time, it doesn't have much to do with actual public health or actual the health of the community. It has to do with other factors that are a little bit more nefarious. And we just have to be able to call that out and acknowledge that.
Yeah.
So while we're doing the work of helping people, we have to also recognize the system that is very much colonial in its structure because it has these hierarchies that are existing to oppress people.
Yeah.
So when people talk about decolonizing like psychology or therapy, that's really what they're talking about is this idea of how much does our field prop up and support these colonial structures, you know? And so anyway, so that is part of I think that's part of the work, and so that's part of the reason why I love doing what I do, especially around addiction, because I have an opportunity to debunk a lot of the mythology and propaganda around that use. And by the way, I'm not the only.
No,
There's so
that's
many people written about this. Yeah.
yeah. No, I'm so grateful. Like your wealth of knowledge and your insight. I think, especially during Black Men's Mental Health Awareness Month, right? Because this is also something important. Because Black men, I believe, suffered the most from the war on drugs. And it's also Black men's health awareness, so that they deserve the most repair in this way from the benefits. Like if there is money to be made, Black men should be at the front of the line getting the harm reduction services and supports from healthcare because they were the most marginalized by this targeted approach. And I think that that's important to call out for me as a Black woman, as a Latina, that I understand the roots and the history of the story that they were trying to tell about my people and the men in my life. And
Right.
I think that we deserve better, and that more women need to say where in our ecosystem do we build the guardrails and support systems for the people who they struck down. And that's just one thing. But as we're thinking about mental health and Black men, and balancing the nuance of holding both realities in a time like this, where your work is so important, and even as we're celebrating wins, and I think this would be a good way to close it out, because I don't know where this will go, but if we're as we're celebrating like wins, like when we're seeing a reduction in opioid deaths and harm to opioids altogether, Black people as a subcategory are not as affected. So even where there are strategies, they're
Yeah.
not actually competent um, approaches to target our well-being, which it
Yeah.
looks good on paper when you're reporting it, but if you dig down in the data,
Right.
there is we're not seeing the impact of the
Yeah.
work. So how
Yeah.
do we set up a new system with that in mind, especially when Black men were locked up, so that we
Mhm.
can see the nuance, and like where do we need to start? Like how do we build
Yeah.
it so it impacts us?
Yeah, I mean that's one of the essential issues for me that is so important to talk about because yes, we're in the last couple of years we've been celebrating an overall decrease in overdoses across the board, but in marginalized populations that's not the case. Like with Black men and with Indigenous folks, that's really not the case. And part of that is really understanding what are the substances that these groups are using. Why is there a proliferation of things that could potentially lead to overdose, and where is the prevention, right? So, in when I talked about how the DSM recognizes continuum, but the institutions don't actually follow that continuum. We have mental health treatment that is geared towards the most severe end of things, and also geared towards certain things. So, like when you talk about overdose, it's mostly geared towards opiate users or IV users, right? But what if that's not your drug of choice? What if that's not your substance of choice? What if for a lot of Black folks, the substances are usually cocaine, marijuana, and alcohol, right? And so if you are someone who utilizes those substances, and like for example with cocaine, and you go to a facility that's is supposed to help you with cocaine treatment. They don't necessarily. I mean, now they may be starting to do it, but they don't necessarily have ways to detect whether in your cocaine supply do you have either tranquilizers like xylazine or opiates like fentanyl. Because what we do know is most of the time there's overdoses. Most of the time it's either two things: either higher potency of some sort of opiate, some sort of respiratory depression, or it's a mix of different substances together,
Mm-hmm.
right? And so we know as far as marijuana, there is no evidence to prove that with marijuana alone that would lead to any overdose. There's no evidence. Now, can you make the call that says marijuana or cannabis impairment can lead to risky behavior, right, or lead to self harm or harm in some ways? Yes, it can. But marijuana itself as a plant does not lead to overdoses. And there's also been some talk about marijuana as it being laced with fentanyl. And again, this really speaks to the suspension method. We didn't really spend a lot of time talking about it, but how you use marijuana and what sort of product you're using is also important. So with most fentanyl, it has to reach a certain temperature in order for it to evaporate, in order for it to have the effects that when you're inhaling it. And so a lot of like vape products don't reach that that kind of temperature, things like that. So we really need to kind of educate ourselves. And speaking about vape, by the way, which is highly unregulated, a lot of people who are using marijuana vapes, it's very hard to control not only potency, but also what we're noticing is a lot of, especially for young people, a lot of respiratory issues, right?
Well, I mean, I learned something wild yesterday that vape companies spend a lot of money and time and research on how to get you high the fastest in terms of technology and vape device build. Like, what's the right temperature? What's the right, like,
Yeah,
pull pressure that you can create before it hits
yeah,
you? Like, how, like, and they're trying to measure how quickly you get high, not right.
right,
And then again, we don't have everyone's making these decisions because they think that chasing the high is what you're supposed to be doing, because we don't have evidence that all these over highs and high potency highs are harmful until, like, again, somebody in Australia started connecting the dots with people that were coming in with gastric issues and were like,
yeah,
the doctors started talking about it, and that's how we ended up with hyperemesis. But if hyperemesis is creating higher ED utilization, right?
yeah,
Where is public health in all of this, in
yeah,
regulating vape companies that are just trying to create, or regulating the
yeah,
technology and the device?
yeah,
Like, you can't be selling no device that's gonna get me high in 3 seconds and keep me high for 10 hours. Like, that's
right,
not safe. So
yeah,
they don't have guard. It's the wild, wild west, my friend. Like,
yeah,
this
yeah,
big with 8
yeah,
cartridges, and they're like,
right,
hey, and I was like,
yeah,
oh my God, all these girls are gonna be throwing up later. But it was
right.
like, where do we say that's not okay, right? Or
Because we
when do we
don't have,
start to say that that's dangerous? If we
right.
don't start to look at it, right?
Yeah, because we don't have any federal watchdogs watching these companies. Because, like I said before, these companies operate on a market demand, not on public health or sort of medical sort of perspective. I mean, all of them probably have doctors on their payrolls,
Oh, they
right?
all do.
They all have doctors on the payrolls, but so does health insurance companies, right? So, and they still, anyway. So, with the disintegration of any sort of actual guardrails to the form of some sort of federal or state, kind of watchdogs to watch out for these things. It is the Wild Wild West. These companies do whatever they want because at the end of the day, it's about how can they maximize profit for their boards, right?
Yeah. But
And so that
what are watchdogs watching though? That's so I go deeper, right? What are watchdogs watching? There's no data. If we don't capture this information, they have nothing to watch. So
well
if we
they have
ignore it,
yeah.
like, what are they going to watch? Because you can't watch a trend we're not capturing.
Well, yeah, and I think you this is kind of what you say oftentimes, right? We can't what we don't see. It's hard to
We can't manage it. Yeah.
Right, right. And I think that's why we need to have more stakeholders involved, because oftentimes those stakeholders are the ones who are observing and witnessing things. And we also need to really, I think, broadly have a coalition. And it's a coalition not made for this idea of prohibition or temperance or, blaming a substance, right? It's really a coalition of saying, like, there are all these different factors in our society that perpetuate harmful use of substances,
Hmm.
right? And then when the harm happens, there's demonization of the people who are using the substances, or demonization of the substance, depends on whether people can make money on that substance or not, right?
Hmm.
And so that is sort of the way it's been done. And we need to really form a coalition of saying, like, it's never really about the substance. We would still have the same marijuana plant if there wasn't all of the prohibition, market demand, all these different things, right? Which had a more balanced CBD THC ratio, which had a lower concentration, right? But that plant in the '60s was also part of the counter culture, right? And we know that Nixon and his friends didn't want a counterculture going on, because they were starting to question what the government was doing. They're starting to,
Correct.
be on college campuses and do that, and so they couldn't have the people be the watchdog, right, of what the government is doing. And so, I mean, all these things are connected, and it's very, like, going back to a counselor's and a therapist's job. I think it's really important for us to see these connections, these intersections. And so when a client comes into our office and they're struggling with substance use, it's really important for us to start to ask the question about what is the context in which this person is living, right? We know some of it because we obviously live in the same society. But what is that context, and how do we? Because I often say, good addiction counseling is very little talk actually about the substance,
Hmm.
and more talk about what is underneath that behavior, right?
I love that.
Yeah.
Yes.
So that, to me, it's like, if you're going in that direction, you're actually going in the right direction, in the sense that you're understanding the aspect of this lived experience, this whole person experience, right? And once consumers or people that you help um, have a sense that you understand them, then they can lean on you to trust you, and then they can be more psychologically flexible to think about, and be expansive to think about other ways in which they can cope with whatever it is that they're coping with, right?
Yeah.
Or ways to adapt or adjust. And so that's, like, I often say, psychological flexibility is really the one of the most important things. If you're going to therapy or you're seeing somebody, you could try to get, because it's not about having control. It's about being able to utilize your strengths and your skills to adapt. You know.
Yeah. That is that is wow. I'm sitting with it because I've had a lot of conversations, and I actually had a conversation with a licensed mental health counselor that is in the cannabis industry. She's an owner and an operator of a company, and the reason she went into the industry as an operator was because of the work that helped transform her perspective, and the stories that she kept seeing on the front lines, and her own experience as a patient with the plant when she hit rock bottom and needed like additional support and insight. So she's very open and welcoming and engaging, and she connects with clinicians that can help educate people and guide them to intentional consumption if that is something that they question. And it's not like she has this practice that she's like, the 420 mental health counselor, but it's like, no, be all of yourself here. And
Yeah.
if that means that yourself brings cannabis, let's talk about that too, right?
Yeah.
And let me connect you with the resources. So in her network is a group of us that support education, communication, governance, and kind of help people manage and tap into the resources. So I think like it's important, if you're thinking of the lowest hanging fruit, your advice and your suggestion is the best suggestion, to really just have the curiosity to see the whole person and
Right.
capture the whole person's experience, because that is that trust building where disclosure happens.
Yeah.
And of course, from my always, risk averse perspective, we're able to see the plant in a way that allows us to prevent actual harm, future harm, and safe and responsible consumption within our existing healthcare ecosystem. And I think that that's the goal. That I'd love to see that, to see us leverage what exists, use the clues that were left behind, and
Yeah.
really start to build the systems, but have everyone at the table, like you said, build a coalition of people who care both about proper integration of cannabis in healthcare, but repairing the harm that the war on drugs caused on health equity. Like you
Yeah.
have to hold both to be able to, you have to see both pieces of
Yeah.
that puzzle to be able to do this work intentionally. So I'm grateful to have you in the network, in the
Yeah.
system,
Glad to
and
be
like
here. Yeah. Yeah.
in the ecosystem, so that when we need some supports and we're able to refer and use each other who can see this objectively. And like I am pro cannabis because I'm a patient, but as a clinician, as a provider, as a consultant, I'm pro infrastructure, pro governance, pro fairness, pro data, and evidence based practice, because that is the only way we're going to learn. And I think my biggest plight will always be that we can't manage what we can't see. So unless we make cannabis visible in healthcare, we're gonna just repeat history, and instead of learn from it.
Absolutely. I echo that, and that's true for I think a lot of substances that, I mean, going back to the binary, right? Like, have you heard like there's some substances that are hard drugs and other ones that are soft drugs? Like, who like again, it's this idea of trying to create a hierarchy even amongst the substances, so you can basically say, well, if you use this,
Then
other
yeah,
term people, other term people use is like California sober. Like, I'm California sober, which means it's like I smoke weed and all. I don't do those hard drugs, right? Again,
yeah, like yeah, no, they forget about it's the behavior. So I think like the exposure of the behavior should guide like the treatment care pathway, but we don't have any way to capture the behavior, and it's the behavior is the issue, not the substance. Like
right? And but you have
it's how you're behaving.
yeah,
Like
and the
I kid
functioning,
you
and the
not,
function,
yeah.
exactly. But we have to start asking the right questions as frontline clinicians about how what are the effects, what are the behaviors, because there's an experience, a profound experience that happens before use. And the other thing I want to add real quick is that what's really experimental, because there's a big gap when it comes to marijuana withdrawal treatment. Like, so there's certain things that the insurance companies have decided that you don't need detox for because it's not acute enough, it's not physiological enough. So stimulants like cocaine, and oftentimes marijuana, right? However, if you've used marijuana and you're trying to get off marijuana, going cold turkey is a very painful experience. And so we also need to start talking about how the treatment system can actually support folks. And so in my small practice, I have someone who is experimenting with synthetic marijuana that they use for folks who have cancer and HIV as a way to help withdrawals and taper off, kind of like how methadone is used to help folks eventually taper off.
I literally said that today. I said one of the biggest arguments of the cannabis industry is like big pharma is going to take over, and I'm like, there is a way for both of them to exist, because big pharma has the capacity to do targeted and minor cannabinoid specific
Mhm.
formulations that could support research and a well-being of other types of patients and illnesses. We need the people who are gonna dig deep into which cannabinoids are doing what. Like we need them
Right.
here. They got the resources to do the work. Like we should not alienate big pharma. We need to be like, hey, come here and let me tell you how the care pathway looks like, and this is how you're going to be successful in your drug trial. So you need to make sure that dot dot dot. We shouldn't
Right.
be alienating that conversation, because there's an opportunity for something like that to exist. Because I was thinking, um, the way we prescribe cannabis as clinicians and the way we recommend is we do ratios, and we talk about CBD and cannabinoids and
Yeah.
THC And even the way we titrate, we don't titrate THC first, we titrate CBD because we understand the effect. But marketing has all been THC, THC, THC. So like we're not even speaking the same language about
Right.
what it looks like to use this well.
Right.
And so that was fascinating what you just said, because it made me go, oh my gosh, we literally
Yeah.
we need pharmacy to look at all the minor cannabinoids. There's actually, and you know what? I'm going to put it in the atmosphere because I hope somebody does this. Or if they need help thinking through it, call me. But there is a CBD trial starting July 1st. It's a federal
Hmm.
trial. There's grant money tied to it. In different care environments, the implementation of CBD.
Hmm.
And you just we don't have data, so like everybody's trying to figure out how does this work, where does it work, and what environments can
Yeah.
it work, how do we use this as part of our ecosystem
Yeah.
as a harm reduction tool. And for clinicians, and we're going to close out because I don't see any other questions yet either, so we're
Yeah.
going to close out in the next 5 minutes.
And listen, we could keep talking for hours.
I know we've
Yeah.
done this before, but
Yeah.
essentially the hardest part for me to get nurses to talk about it is they don't even know the endocannabinoid system exists. So if you don't
Mm.
understand that there's an entire system in your body with
Right.
specific receptors, then you're not going to think of it as a medicine, because
Right.
medicine has a pathophysiology about it, and you learn that and you understand how it's metabolized in your body, and
Yeah.
then you can make recommendations and you understand with the information that's provided. But we
Yeah.
don't have that, and like that's typically provided by the FDA pathway. There's a
Yeah.
way to create a makeshift formulary and use patient experiences, but like the grassroots efforts of data collection is just talking to the people and
Yeah. Yeah.
understanding how they're using the plant, why
Yeah.
they're using it, how many
Yeah.
times is there co-exposure
Yeah.
of cannabis and alcohol, co-exposure of cannabis and supplements, co-exposure of cannabis and prescription medications. So we know if there's actually a risk of, like, how much energy should we be putting to med reconciliation efforts if we
Right.
don't understand if there's even a co-exposure. There's co-exposure, y'all, because the survey, the data that's going to be coming out at the end of the summer through the
Yeah.
study with the partnership with Harvard School of Public Health, is the early data showing us that people are consuming cannabis and other things all the
Yeah.
time because
Yeah.
they don't have the education that there's anything wrong with that,
Yeah.
and they
And
don't they don't know what the risks are.
and historically, people. So cannabis is not going anywhere, right?
No.
It's not going. And so historically, people have used cannabis in many different ways. And what this prohibition sort of stance is not allowing really for any of these sort of plants to really come into understanding how we can use them. And I think that the endocannabinoid system, this regulatory system that affects processing and central, that's so key. But even in counseling school or in master's level, there's like one really poorly done substance use course, and most of it is not even talking about these kinds of things. So if you're a therapist and you are not well informed about how these substances affect the emotions and the processing and the memory and all that stuff, you're really doing the person in front of you a disservice. So I think what you're talking about is all these systems don't. So all these systems are designed to work in their own silos. We need to bring these systems together. But why we need to bring these systems together has to do with listening to the people. Because if the people are not at the center for why we are doing what we're doing, then we're running the risk of going back into what we normally do, which is just follow a market demand and follow what the status quo wants. And so, I think cannabis and other substances can play that role to bring people together in many ways. The people who are severely affected by it, and the people who all the way on the other spectrum who are not, and really try to understand that how all these different intersections are working in play to affect, because it is about someone's genetics. It is about the amount of cannabis they use. It is about all these different things, environment, mood, all these different things impact how cannabis affects somebody. So we need to kind of listen to more of those things.
No,
We
and
know that.
I'm grateful. Yeah, I'm grateful for the work. I think loving to talk to people became a very useful gift, right? I love having these conversations, so it's important to just document them and capture them as data and do it in an organized way because this information is the beginning of something that we need to really start to look at healthcare a little bit differently. I'm super excited as we're closing out. To have had this time and this moment with you. This was such a timely conversation because I'm literally fresh off the circuit in the industry and seeing how much we do that is not guided by safety and like we're not paying the dues that we need to pay for having the abundance that they get to have to a
Mm,
healthcare system that has traditionally failed a group of people. And I think it's really important to think of that. But as I was thinking about this, I was thinking about beyond the stigma conversation, there's a very prominent safety conversation that keeps emerging from this lack of visibility.
mm,
I actually scheduled next week's guest session, Five's guest, right after yours, because as I was describing our conversation, I actually talked to him the same day I talked to you for the first time. And I was like, I
yeah.
just had this really great conversation about this. And then he goes, yeah. And then he adds another layer of thinking, which is, the documentation, co-exposure, and the clinical work required to be able to define and understand what we need to understand to do something about it. Because data capture is nice, but now there needs to be this other clinical layer of work and science that
Yeah.
supports, like you said, there needs to be an education and academic commitment to teaching the endocannabinoid system. And I've learned that in spaces like this, mandates are the ones that really push. So I really hope the fact that there's a Schedule 3 the executive order that says we need to treat this as medicine really triggers people starting to think of it as medicine. But there's a lot of clinical work required, and we need an army of thought leaders and infrastructure builders and ecosystem expanders that can see the needs of medicine in this space and are willing to listen to the people who've been most impacted by this medicine and build the systems around and build a less restrictive and frictioned system so that we can actually see these people as patients. So it's going to be interesting to talk about his roles like an educator and a scientist and an entrepreneur and what he's thinking about the documentation gaps that he's seeing in trying to do research, because you can't do analysis without data, right? So
Mm,
we have to do the data collection so that the people who analyze it and use it can use it. So this is, it's starting to feel like the conversation is
mm.
leading towards action, which is, I think, that
Yeah.
we'll move towards. So I'm going to leave you. You get to close this out because I'm going to say this was an honor to have you here. But if somebody were to like zip through the end of this video and not listen to a word we said, and you
Yeah.
had 2 minutes to tell them the most important thing that you wanted to tell them or the most important takeaways from this conversation, what would you leave them with? And I'm going to actually give you the stage.
Okay. So I'll just take a page from your book when you say healthcare cannot be manage what they cannot see, and I'll say that when systems only recognize addiction at its most severe, then they miss the social, psychological, and structural factors that we've been talking about that shape substance use to start with, long before a diagnosis is ever made. And so we need to be able to see and observe and recognize the whole spectrum of use and normalize it. And as I think as addictions counselors, we have a responsibility to do that. And it sounds like there are a lot of people who are of like mind in different fields who want to make sure that we center people and that we get away from these sort of archaic ways of viewing substances uh, solely as like substances exist in a bubble. We know that substances have a historical component of being legal ways to disenfranchise to marginalize, to oppress people. And so we don't want to perpetuate those things in our field. And we have to talk about disentangling the colonial structures that our field still hold up. So that's how I'll end. And thank you so much for this
That
time.
was so dope. Thank you. That was great. I was like, go ahead and preach, Zoe. Thank you. Thank you for your time. Thank you for your energy. Thank you for your audience. And I love that we're lifelong learners and we're very curious in this way. And I hope that these conversations don't end anytime soon and that we actually can start seeing the fruit of the labor of the work of bringing this curiosity to the forefront. Thank you so
Absolutely.
much. I'm going to end the live stream and yeah.